All right, so going into our video on the extensor forearm and the dorsal hand, this is a video brought to you by the Scrubs team, which again stands for the Student Collaborative Resources for Understanding and Birdie Success. Going through our mission statement, Scrubs is a student-driven initiative that is aiming to develop supplemental resources for current and future cohorts that are going to be passing through Brody. Members of the Scrubs team are participating in a variety of subcommittees to work on creating resources for students, by students, and this offers a unique perspective of a student who has gone through the curriculum as opposed to the view of an instructor. Now, the hope is that this organization will become a staple of the Brody student body, and we're looking forward to you joining in on that initiative. That is something that aligns with your goals. With all of that said, I do need to put in a quick disclaimer that these resources are student-derived, and that means that even though we go through multiple stages of vetting, there is potential for error, although we try to limit this as much as possible. So with that, be aware that if there's any discrepancies between these materials and your primary course documents, please by all means go with your primary course material. Additionally, Scrubs is a supplemental resource and does not does not replace the instruction by the Brody faculty at any point. So please utilize this resource to the best that you can, but do recognize that it is a supplemental student-derived resource. Okay, so as we're getting into the extensor forearm and dorsal hand course pack chapter, this is a brief review. If you want more in-depth information, go to our flexor forearm video. But remember the osteology of the wrist and the hand. When you're looking at the wrist, you've got the proximal bones. If you go from lateral to medial, that is going to be from your thumb side to your pinky side. You've got your scaphoid, lunate, triquetrum, and pisiform. So you can see those labeled down here. And then if you go distal, so closer to the fingertips, you're going to have the trapezium, the trapezoid, and then you're going to have the capate, and then you're going to have the hamate. Okay, so that goes from lateral to medial. And a little way to remember that is this mnemonic: some lovers try positions that they can't handle. So the first letter there corresponds to the bone. You just have to remember to start proximally below the thumb and then work your way more medially. And then you can go distally and work your way medial on the distal road. Okay, so when it comes to actual content of this particular course pack chapter, a lot of it focuses on muscles and their innervations. So we're going to start with muscles of the superficial extensor forearm. So there's going to be 6 muscles here that we're going to talk about, and it's important to group these as best as you can. So the first one we're going to talk about is the brachioradialis. The brachioradialis is labeled in red up here at the top. So notice that it is the most lateral of these muscles, because remember, lateral is going to be the thumb side. It's important to know that when we're looking at this hand is going to be pronated. So this is not anatomical position. This has the wrist pronated, so that way we can see the extensor compartment. So most lateral over here is your brachioradialis. It is going to originate from the lateral supraepicondylar ridge in this region here, and it is going to insert onto the distal end of the radius. So this muscle does not cross the wrist joint. It is innervated by the radial nerve. All of the muscles that we're going to be talking about today are going to be innervated by the radial nerve, just different branches of the radial nerve. The radial nerve has spinal segment C5 through T1. And this particular portion is going to be innervated before the radial nerve branches. So this is the main radial nerve. And its main action is going to be to flex the forearm. So this is an interesting action because it's in the extensor forearm compartment, but its action is going to be to flex the forearm. Okay, and that's located once again in red right here. The reason it acts on the forearm is acting on the elbow joint because it crosses the elbow joint here, but it does not act on the wrist because once again, it inserts into the distal end of the radius and does not cross the wrist. Next, we have our extensor carpi radialis longus. As you can imagine, the name is going to give you a pretty good idea of what this is going to do. It is going to extend. It's an extensor, so it's an extensor compartment located back here in the posterior forearm, and it's going to cross the wrist. That's the carpi, and then radialis longus, meaning it's on the radial side, and it's the longer one of the two. So it's going to be located right here. So that's your extensor carpi radialis longus. Okay, this is also innervated by the radial nerve before it branches. So these two muscles that start in this location on the lateral supraepicondylar ridge, they are going to be innervated by the radial nerve before it branches. Its insertion is into the base of the second metacarpal of the dorsum of the hand, and this is going to allow it to have the action of extending and abducting, so abduction, radially deviating, bringing the thumb closer to the forearm on this side, the hand, and is innervated once again by the radial nerve before it branches. Okay, so that is the extensor carpi radialis longus. The next muscle that we're going to talk about is the extensor carpi radialis brevis. So it goes brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis. So the brevis is going to originate from the common lateral epicondylar tendon, and it's going to insert into the base of the third metacarpal. So you had second metacarpal with the longus, the third metacarpal with the brevis. It is innervated by the radial nerve, once again, C5 through T1, and this time it's going to be innervated by the deep radial nerve, so the branch that is deep. We'll talk about the nerves and their particular pathways towards the end of this video, so for now, just kind of take that down as a note, but we'll put it all together at the end. And this action is going to be, once again, to extend and abduct the hand. Okay, so having the same function as the extensor carpi radialis longus. The next one, coming right down the middle on the posterior aspect of the forearm, this is going to be your extensor digitorum. This is going to originate, once again, from the common lateral epicondylar tendon. So the lateral epicondyle is going to be the origin for a lot of your extensor muscles. The insertion is going to be the extensor expansions, located right here, of digits 2 through 5. So not digit 1, which is the thumb, but 2 through 5. It is innervated by the radial nerve. Specifically, it's going to be innervated by the posterior interosseous branch of the radial nerve. And this action is going to be to extend digits 2 through 5 and assist in the extension of the hand. Okay, I do want to point out the Cutaneous can also be seen in this particular image. It's located right here. Right, there goes your Cutaneous. And in the course pack, it's not actually listed under the extensor forearm and dorsum hand. It's going to be listed under the posterior brachium, because it's going to act on the elbow. And then two other muscles that we can see in this image that we're going to talk about in more detail in the next slide is the extensor carpi ulnaris. So this is the most lateral of your superficial extensor forearm coming to the wrist. And then we can see the extensor digiti minimi coming down right through here in green. But we'll touch on those in just a second on our next slide. Okay, so now we're continuing to talk about the muscles of the superficial extensor forearm. We started most laterally and we're working our way medially. So when we did that, we had our brachioradialis, right? Then we're coming more medially. We had our extensor carpi radialis longus. We had the brevis, right? Then we had our extensor digitorum. And now if we come more medial to the extensor digitorum, we see that there's an additional muscle fiber that's coming to our pinky. That is going to be your extensor digiti minimi. Okay, so extensor digiti minimi is going to originate on the common lateral epicondyle tendon. It's going to insert into the extensor expansion of the fifth digit, innervated by the radial nerve, specifically the posterior interosseous nerve. So that is a branch of the radial nerve, and it is going to extend the fifth digit. Okay, and then the last muscle of our superficial extensor forearm is going to be located most medially. I know this is medial because it's on the same side as the pinky, right? So in anatomical position, this muscle will be located medially. This is going to be your extensor carpi ulnaris. So the extensor carpi ulnaris is going to originate from the common lateral epicondylar tendon. You notice that is a trend for most of these muscles. It is going to insert into the base of the fifth metacarpal, and it is going to be, its action is to extend and adduct. So that's ulnar deviation of the hand. So that's different than the carpi radialis muscles, which are going to abduct. This one is going to adduct, okay? And that's the main difference between their mechanisms. And then the nervous innervation, again, the radial nerve, specifically the posterior interosseous nerve. So we talked about muscles that are in the superficial forearm, but now we need to talk about a little bit deeper. So this is removing the superficial muscles and taking a dive down in the deep layers. So all of these muscles, once again, are still going to be innervated by the radial nerve, which is C5 through T1, but these are being innervated by different portions of the radial nerve. The first muscle, so this is going to be the most lateral of the deep muscles. So again, thumb side is going to indicate lateral. So lateral over here, we have our supinator. Our supinator is going to originate from the lateral epicondyle of the humerus and the ulna, and it is going to insert into the radius. Okay, this nerve acts to, this muscle acts to supinate the forearm. So that's going to bring your palm face up. And then the innervation here is going to be, once again, by the radial nerve, but specifically the deep radial nerve. Now, if we come a little bit more medially, we're going to have our abductor pollicis longus. So our abductor pollicis longus is going to be innervated by the radial nerve, the posterior interosseous nerve specifically. It originates from the radius, the ulna, and the interosseous membrane, and it is going to insert into the base of the first metacarpal. So you can see that coming down here, the base of the first metacarpal. Okay. Now, this muscle acts to abduct the thumb and extend it at the carpometacarpal joint. So abduction of the thumb and extension at the carpometacarpal joint. Next, we have the extensor pollicis brevis. The extensor pollicis brevis is going to originate from the radius and interosseous membrane and insert into the proximal phalanx of the thumb. So it's going to be located here. So this is different than the extensor carpi, radialis, longus, and brevis, and the orientation is flipped. The brevis is located more lateral, and the longus is located more medially when you're in the deep layer. So extensor pollicis brevis is going to do exactly what it says. It's going to extend the thumb at the metacarpal phalangeal joint, and it is innervated by the posterior interosseous nerve. Another nerve that we're going to talk about in more depth moving forward, or so a muscle that we're going to talk about in more depth on the next slide, is the extensor indicis, and you can see that located here in blue going to your index finger. So rounding out the last two muscles of the, this should be the deep extensor forearm. You're going to have your extensor pollicis longus. So we said the brevis was located more laterally. The longus is located more medially. So it's coming around. You see that it has a longer pathway that it has to get to the thumb. It is going to originate from the ulna and the interosseous membrane. Insertion is into the distal phalanx of the thumb. And innervation is once again by the posterior interosseous nerve. And this action is going to be to extend at the interphalangeal joint. So extending at this joint here. All right, so that is the extensor pollicis longus. Now, the most medial of the deep muscles of the deep extensor forearm, that is going to be your extensor indicis. So your extensor indicis is located here, following this pathway to your index finger. It is going to originate from the ulna and the interosseous membrane, and it is going to insert into the extensor expansion of the second digit. Now, it's innervated by the posterior interosseous nerve once again, and its action is going to be to extend at the metacarpal phalangeal joint. So that should take us through all the muscles of the extensor forearm. Now, something that is important with this course pack chapter is knowing the anatomical snuff box. So the anatomical snuff box is located in the wrist. It is this triangular space on the posterior lateral aspect of the wrist. And you can actually feel this in yourself, in your hand. If you extend and abduct your thumb, you'll be able to feel the tendons that make up the border of this snuff box. So when we're talking about the borders are going to be the abductor pollicis longus and extensor pollicis brevis. Those are located down here. These are the more lateral borders. So remember, in anatomical position, this is the lateral border because the thumb will be the most lateral object in anatomical position. So you have your, down here below, the abductor pollicis brevis. And then right here, you have your extensor pollicis brevis. Now, this tendon above, located more medially, is going to be your extensor pollicis longus. Okay, so those are the tendons that make up the triangle that makes up the anatomical snuff box. Now, in this image above, you can kind of see in a little bit more clarity that there are some important structures that run through this region. So the important contents of the anatomical snuff box are a major branch of the radial artery, runs through the anatomical snuff box, a branch of the radial nerve, the proximal end of the cephalic vein, which you see here, and then you have the bones that are deep that form the floor of the anatomical snuff box. This is going to be the scaphoid and trapezium. Okay, so it's important to know that all of these structures are located in the anatomical snuff box because you are likely going to get a question at some point saying that someone has pain in the location of the anatomical snuff box. And when you see this, pain of the anatomical snuff box after trauma suggests a scaphoid fracture. And that, once again, is because the scaphoid bone is located just deep to the borders of the anatomical snuff box. Okay, so nervous innervation, again, you've probably figured out at this point in the course that it's pretty important to recognize nervous innervation for all your muscles and understand if there's a lesion at some point along the pathway, what kind of damage that would cause moving forward. So we want to talk about the muscular innervation first, and then we'll talk about the cutaneous innervation of the extensor forearm. So for the muscular innervation, everything is done by the radial nerve. Okay, so the radial nerve is going to innervate all the muscles of the extensor forearm. Now that said, there are a couple of different components of the radial nerve that we need to be aware of. So let's look at this main branch of the radial nerve coming down the arm. And you can see that it's going to branch into a superficial branch. And then it's right here, going to the skin, and it's going to branch into a deep branch, going into the forearm. So before it branches, right in this region, that is where you're getting components that are innervating the brachioradialis and the extensor carpi radialis longus. So that is the common radial nerve is innervating the brachioradialis and extensor carpi radialis longus. Now, if we follow the deep branch, we can see that it actually punches through a muscle. The muscle that it punches through is the supinator. So the deep branch is innervating the supinator and the extensor carpi radialis brevis. Okay, so two muscles and two muscles for both of these branches that you need to keep up with. Lastly, if you continue through the supinator muscle, the continuation of that nerve is going to be called the posterior interosseous nerve. Okay, so the posterior interosseous nerve is going to innervate all of the remaining muscles of the extensor forearm that we talked about previously. So that is your muscular innervation. Right, now if we move to cutaneous innervation, there are going to be a couple of different components that are going to innervate the cutaneous innervation of the extensor forearm. The first is the lateral antebrachial cutaneous nerve. The lateral antebrachial cutaneous nerve is a continuation of your muscular cutaneous nerve. If you need more detail on that, refer back to our brachial plexus video. Next, we have two other nerves that are going to come off. You're going to have another nerve that comes off from the brachial plexus. This is going to be your medial antebrachial nerve. Okay, and that is coming directly from the brachial plexus. Next, we have a branch from our radial nerve. This branch actually happens up here in the arm or in the brachium. This is going to be your posterior antebrachial nerve, okay, innervating the posterior aspect of the forearm. And lastly, you have the superficial branch of the radial nerve that comes through and innervates the cutaneous components of the forearm, and we'll go into more detail into that in just a moment. Okay. So something that's relatively important when it comes to testing is knowing the cutaneous innervation of the hand. We talked about this when we talked about the palmar surface, so we've seen that already, but now we're going to talk about the dorsum hand. So the cutaneous innervation of the hand is really made up by three nerves. You have your ulnar nerve, your radial nerve, and your median nerve. So your ulnar nerve is going to have a couple of branches that are innervating. So your ulnar nerve, just so you can reference for the image, that is going to be in blue, like very light blue. And you can think that ulnar nerve is on the same side as the ulna, so it will be innervating things in relation to the pinkies. So on the pinky side of the hand. So the branches here that are innervating the dorsal part of the hand is going to be your dorsal cutaneous branch, which is going to have spinal segments C8 through T1, and that is going to do the medial 1.5 digits. So 1.5, that's why you can see the split innervation coming down this fourth digit here. Next, you're going to have your radial nerve. The radial nerve is indicated in red in this image. So the radial nerve branch that innervates the dorsum hand is going to be the superficial branch of the radial nerve, which we talked about previously, and it is going to innervate the lateral half of the dorsal hand, and then it's going to innervate the proximal 3.5 digits. Okay, so this is a little bit of a weird one, but it's going to innervate the proximal 3.5 digits. The fingertips here for these digits are actually innervated by the median nerve, and that's by the palmar cutaneous branches, which have spinal segments C5 through T1 contributing. All right, and that does the distal portion of the dorsum hand when you're looking at these phalanges. Now, I do want to point out something to note on the dermatomal distribution. You can get questions where you get asked the dermatome for the thumb, the dermatome for the pinky, the dermatome for the middle finger, for instance. It could even be split on the index finger, the ring finger. And then what you need to point out is that the thumb is going to be indicating dermatome C6, middle finger is C7, and the pinky is C8. Okay, so if you work your way across, thumb is C6, C7, C8. Okay, this is a slide that I threw in here just for a quick review. We're not going to go into any detail with it, but feel free to come back to this if you're looking for more information on the arteries of the flexor forearm and extensor forearm. But go back to the flexor forearm video for a more in-depth view. Now, I do want to point out in the extensor forearm, there are a couple of vessels that we do want to keep in mind in addition to those in the flexor forearm. The first is the radial artery right here. So the radial artery is coming off, it's a major branch of the brachial artery, and it's going to come down the radius, so more laterally. And it is going to give off a recurrent radial branch, which we can see indicated here. Okay. And now we also remember that we have the posterior interosseous artery, which is a branch of the common interosseous artery, which is located right here. But it gives off that posterior branch, and that posterior branch is going to be running down the posterior forearm. Okay. And then what I want to point out is the region of the anatomical snuff box located right here. Remember that you have that branch of the radial artery, and that branch of the radial artery can be damaged, right, if you have injury to the anatomical snuff box. Okay, with that, let's get into some actual clinical anatomy. The first thing that I want to talk about is radial nerve lesions. So this is a image from Amboss. I think it does a really good job of walking you through the different components of the nerve that innervates different musculature. So what I would recommend is walking through this image on your own, and then imagine if I had a lesion that occurred at this location of the radial nerve. What muscles would lose innervation distally, right? And so here is your muscular components, and then over here you can see your sensory components. And what's nice about this particular image is it lays out each one of the muscles over here on the right, and then the sensory innervation over here as well. Now, when we do talk about radial nerve lesions, the actual presentation of that is going to present as wrist drop. So lesions of the radial, and this is particularly damage to the radial nerve in the arm or the cubital fossa, that is going to paralyze all of the extensor muscles in the posterior forearm. So when we have paralysis of the extensor forearm muscles, you're going to get this wrist drop when you hold the arm out straight, and that's because you've lost the extensors. In addition to that, you're going to have some sensory region deficits, and that's because if you damage the radial nerve in the arm, right, then you're going to lose that superficial cutaneous branch. So that is going to mean that you're going to lose innervation to the dorsal medial portion of the hand, or sorry, dorsal lateral portion of the hand, indicated here. So remember, anatomical position, palm is up, and then this is going to be looking at the posterior aspect of the hand. So this is going to make this lateral. Right, so those are the main things that you should be looking for when you're looking at the wrist drop. Now, because the lumbricals are still innervated by the median nerve and ulnar nerves, you still are going to be able to flex the metacarpal phalangeal joints and extend the interphalangeal joints when you have this radial nerve lesion. But the wrist is going to drop because of the loss of the long extensors of the forearm. Okay. The next thing I want to talk about is tennis elbow, which is also called lateral epicondylitis. So this is when you're talking about the lateral epicondyle. And remember, we had a lot of those insertions for these muscles at the lateral epicondyle. So this is an overuse injury. So this is especially due to having the finger extensor tendons being stretched. So this is most commonly due to repeated excessive pronation and supination of the wrist while the wrist is extended. So this is why it's often called tennis elbow, because that is the motion that is going to stress these muscles and their insertion points. So here you go. You can see that the insertion into the lateral epicondyle. And this is really going to be, it's going to cause pain, and it's injury that of overuse. So their treatment for this is going to be low-dose NSAIDs, and then you're going to tell them to rest, ice, that kind of thing. Now, to test this in the clinic, the way that you do this is you hold the patient's hand with your thumb placed over the lateral epicondyle. So you're putting pressure right there on the lateral epicondyle. The patient is going to make a fist. They're going to pronate the forearm, and they're going to radially deviate the fist against resistance. And this is causing them to contract these muscles that are inserting onto the lateral epicondyle. And if you get pain, then that is a positive test. Okay, the last clinical correlation that I want to talk about is a FOOSH injury. This stands for a fall on an outstretched forearm or outstretched hand. So this is going to be a fall of the hand when the hand is pronated and the wrist is extended. So when you reach out and put your hand out in front of you, imagine just falling down on that to catch yourself. Now, this is a common cause of fracture to the radius and the scaphoid. So your radius and your scaphoid. And what I want to point out here is that this is often going to cause anatomical snuff box tenderness. Okay, so if you have tenderness over the anatomical snuff box, be suspicious of a fracture to the scaphoid. Right? Now, because you can see the vascular supply that supplies the scaphoid and the other structures in this region, if you have a fracture, it is possible for you to lose the blood supply to this region due to injury. Now, this is going to cause avascular necrosis. Avascular meaning lack of blood supply, necrosis meaning dead tissue. So it can cause the bone to die because of lack of blood flow. And because this takes a little while to happen, if there's an initial injury, you often may not be able to see this on x-ray for up to 14 days. So because of that, if you have pain in the anatomical snuff box, you really need to have a high clinical suspicion for a scaphoid injury. Right. And with that, that'll bring us to a close with this video.